Hello, everybody. Happy Monday. Welcome back to our CCRN webinars. Today, we are going to talk about neuro, as you can see. Just a quick one today. We're just doing 30 minutes, going through some questions, and then we'll talk about neuro-related concepts that relate to those questions. So super exciting. Kind of switching it up a little bit content-wise. My name is Rebecca Coulter. In case this is your first time joining us for a CCRN webinar, I am the CCRN instructor here at Archer Review. We just launched a whole CCRN course with 13 and a half-ish hours of video lecture material and then a 1,000 plus question Q bank. And we're adding to it kind of all the time. So super exciting stuff. Right now it is free for a limited time. That is changing. So definitely run in there and get it free. And then we're offering also a 30-day option and a year-long option. So super exciting stuff. Really quickly going to talk briefly about the CCRN. Let me pull my slides up here. There we go. Just to orient you to what exactly the CCRN is. Again, if this is your first time, we've been doing these webinars for a while, but we know we've got people joining all the time. So CCRN is a critical care nurse certification. It's offered by the AACN as the organizing board. And it is a test, a certification exam that you can sit for once you've achieved a certain amount of experience in an ICU or a critical care setting. So that amount of experience is about 1,750 hours. If you're working full time, you'll probably hit that in your first year. Some people like to wait a little bit longer to take it just to gain some more experience, and other people knock it out as soon as they can. So really up to you on that. When you do sit for the exam, you'll take 150 questions. Only 125 will be counted, and you need 83 correct to pass. It's considered a difficult exam. Only has an 81% pass rate, even though that 83 questions correct is around, oh gosh, I think I forgot, like a 67% or so. So yeah, it's considered difficult, which is why Archer Review has come together to have a product for it to help nurses prepare. And like I said, right now it's free. So head over to archerreview.com/CCRN and you can see that product. We also post all these webinars that we do over on that site. So if you go to that CCRN webpage, all of our free webinars are posted there. We do some webinars that offer CE hours, so you can get a certificate and have some hours to report if you need that for your nursing license or education requirements at your hospital. If you are already CCRN certified and you need to sustain your CCRN certification, you can use these CE webinars to do that, and those are also free. So keep an eye out on there for when we're offering those CE webinars. We'll have one next Monday, which I'll talk about here at the end of this webinar. Okay, like I said, my name's Rebecca. I am an ICU nurse. I've been an ICU nurse the whole time I've been a nurse. I specifically worked in cardiac nursing, ICU nursing for the first 4 to 5 years of my career. And since then, I've been in more of a general ICU, which has been really good to broaden my experience so that I can talk about things like what we're talking about today, which is our neuro concepts, which for a really long time were very uncomfortable for me because I was so specialized in cardiac surgery and cardiac medical care. But one thing about neuro is it's kind of like cardiac in a way. You do see it with you have the chance to see it with every single patient. I mean, there were so many times with our cardiac patients that they can experience strokes from being on blood thinners, ischemic strokes from AFib. There's lots of different reasons that we can have neuro considerations for our patients, and it's something we're watching out for with every single patient, no matter what type of ICU we work in, and no matter what the reason is that that patient is on the unit. They can always be at risk for a neuro concern. So it's something to feel good and comfortable about. But I know that if you're anything like me, you typically fall into one of two camps. You either like the heart or you like the brain. And if you like both, congratulations. I wish I was like that. But I definitely prefer the heart. But I am excited to talk about what we have slated for today. Really quickly, if you could just tell me where you're joining from, either location-wise or where you're at in your nursing process. Are you still in nursing school? Are you a new grad? Are you a seasoned ICU nurse looking for certification? Where are you at in your process, just so I kind of know who I'm talking to today? And maybe I'll see if we've got some familiar names. Because I know I typically see names over and over again, which I think I do, looking at some names. Okay, about to take certification in 2 weeks. Woohoo! That's so exciting. You'll have to tell us how it goes. Um, we'd love to hear how it goes for you. Um, that's very exciting. CVICU nurse, 3.5 years of experience, want to take the certification in 3 to 4 weeks. That's awesome. I started in CVICU, like I said, it's so fun. Love it, love it. 3 to 4 weeks. That's awesome. That's a great amount of time. Everyone takes such a different amount of time to prepare for this exam. I think I took about 2 to 3 weeks total. I did not prepare over a ton of time, but I did kind of wait until I had been an ICU nurse for many years to take it. It took me a while to find a hospital. Not that I searched for a hospital based on this, but I finally worked for a hospital that was going to reimburse me for taking it. And I thought, okay, now it's really worth it to me. Now I'll take it. Because at first it was my hospitals just weren't offering any incentive for it. So I hope that your facilities are, or maybe you're going back to school and that is your motivation for taking it, another really good motivation. I love being certified. I feel like being certified has really increased my bedside confidence. And just the act of preparing for this exam really taught me a lot. There were a lot of things I learned that I was like, wow, I can't believe I've made it this long without knowing some of this information. So it just made me more confident in having conversations with providers and all sorts of things. New NICU nurse. Awesome. That's exciting. Okay. You're here from Sarasota. Awesome. Okay, let's go ahead and get started. Thanks for interacting with me, guys. Just fun to know where everyone's at. Ooh, RN with 1.5 years experience in South Africa. Awesome. I love when we've got international people here. That's super exciting. And neurotrauma. Okay, Ashley, you can maybe teach me some things too, depending on what we talk about today. That's exciting. Okay, let's go ahead and get started with this first question. We have a patient with a severe TBI or traumatic brain injury, has an ICP of 28 and a CPP of 55. The patient is receiving mannitol, but ICP remains elevated. Which advanced intervention should the nurse anticipate next? You can throw your answers in the chat. I think I have it set so that you don't really see each other's answers. No judgment for me. It's just good experience to commit to something, and then I can see where we're at and what we maybe need to focus on when we review some of these concepts. Thanks, Shakira. So got one answer. I'll give it another couple minutes here. Drink some Diet Coke, my favorite part of the day. Anybody else? This one's a little bit tricky. I kind of picked tricky ones. I'm not going to lie. Not really tricky, but just a little bit more challenging. Yeah, okay, awesome. So the answer for this question is going to be B, a decompressive craniectomy. We want to take some of that cranium out. We know that the cranium is a rigid box, and we've got brain, blood, and CSF that make up the contents of that rigid box. And if one of those gets out of whack, or multiple of them do, we can increase our ICP, and we can affect that rigid box by taking some of the cranium out, some of the skull out with a craniectomy to relieve some of that pressure. We keep that bone flap. The patient does get it back once their ICP reduces. But for this patient with an ICP that high that is still not getting any sort of relief, we would like to see some sort of procedure. Some other people said A, initiation of a propofol infusion. Great idea. We know that we want to subdue our clients, our patients. We don't want to have them really overstimulated. We know that that brings brings us to an increase in ICP. So if there was something in the question that told us, they're still a little agitated, they're on the ventilator, which hopefully they are, then we could maybe advocate for a propofol infusion. If we don't have that information, I want to do something a little bit more aggressive to get that ICP down. So that's when we'll do that decompressive craniectomy. Our other options here, C and D, which I don't think anybody mentioned. Hyperventilation is kind of a debated intervention that we can do for ICP, and it does come with some risk. If that PCO2 PaCO2 drops too low, we can have some cerebral ischemia, so it's got a little bit of risk associated with it. Why would we not do a lumbar drain for this particular patient? Can someone tell me? Even though nobody picked that as an answer, so I have a feeling y'all know. What's the reason D is wrong? Anybody? I'll give it just a second. So the reason that we don't want to do a lumbar drain for this TBI patient with elevated ICP is the risk of herniation. When we have really severely elevated ICP, and we drain CSF off that lumbar drain really quickly, we can cause herniation. Let's see here. And it also, actually, it might not effectively reduce the ICP enough. We would likely need a ventriculostomy. Yeah, exactly. We would maybe need to access into the brain. And also, again, just that risk of herniation. If we're using a lumbar drain, which is below the brain, it can pull things down in that direction, which would be quite dangerous, especially when the ICP is that high. Okay, great job. I've got content on ICP coming up, but I want to ask some more ICP questions, and then we'll do some review of ICP management. Okay, for instance, here's another one. Patient with a Glasgow Coma Scale GCS score of 6 develops decerebral posturing during suctioning. The ICP monitor shows a transient spike to 35. What is the most likely cause, and what should the nurse do first? Okay, a couple different answers for this one I'm seeing. Which that in my mind is never a bad thing. It means that it's good that we're here learning together when I'm seeing multiple answers, but for the most part, I'm seeing the correct answer. So the correct answer for this is going to be C. This is a stimulation-induced ICP spike. We would pause suctioning. We're obviously overstimulating this patient, which is kind of what we were just talking about. We want to keep these patients really understimulated, but it means if they're on the ventilator, the low GCS like this, meaning they should definitely be on the ventilator, we still need to manage their airway. So suctioning is not something we can completely avoid, but it is something that if we have an ICP monitor, then we want to be paying attention to what that suctioning is causing for the patient and limit suctioning when possible. And also pause it. If we're seeing that transient spike, let that ICP come back down. Now, every other answer for our Cushing's reflex, brainstem compression, and seizure activity, we can see all of those things with an ICP spike, but it would be, or a raise in our ICP, but it would not be transient. A Cushing's reflex, brainstem compression, and seizure activity are typically going to be caused from a prolonged, extended period of time of higher elevated ICP. It would not be as associated with that stimulation from the suctioning. So with that spike during something that we know raises ICP, then we are assuming it's transient and stimulation induced. Great job. Okay, next one, changing gears just a little bit. Patient with refractory status epilepticus is on levetiracetam. I always kind of struggle with that one. And phenytoin infusions, in addition to frequent midazolam bolus doses, but continues to seize. An EEG confirms ongoing epileptiform activity. What is the next step in management? So status epilepticus here. Okay, got a couple answers. Anyone else before I give it away? Excuse me. Okay. So again, I saw a couple different answers. The answer for this one is going to be B. We are going to initiate a propofol coma, which coma kind of makes it sound like a more intense option. We just know that we're obviously sedating our patients when we give them propofol. Propofol is an excellent agent. If you have somebody who is just continuously seizing, to be honest, it doesn't take status epilepticus, which is typically when we're having seizing without any sort of break in the seizing at all, or just really, really frequent seizing and very minimal time in between seizures. It doesn't even always take that criteria. If we are at that point where we've got them on baseline, more chronic, yes, Marielle, this is for CCR interview, more chronic management with, Keppra and different medications. They're getting midazolam boluses for their status epilepticus, and we're still not stopping that seizure. We really need to sedate them. Seizure activity is super dangerous for brain activity. Now, the other answers that I was seeing probably the most would be stat MRI of the brain. This is probably appropriate. This patient likely, we probably want to diagnose what's going on with this brain tissue that's causing this epilepticus, but it's not going to fix that current problem, and we need that seizure to stop. It's, like I said, really, really dangerous, especially once we're past that 5-minute mark, which tells us we're in status epilepticus. We're just killing brain tissue. So first priority would be a propofol coma. If they're not intubated, then we would do a consent for intubation. Doesn't necessarily need to be super emergent. I've definitely seen that before where we've had a patient completely with it, alert, but seizing frequently. So they were having pauses between their seizures and brought them into, the doctor came in and said, look, I'm so sorry, but we're going to have to put a tube in just so that we can have you on a propofol infusion because it does such a good job of stopping the seizure activity. So that's the priority, is getting that to stop. And then we could go and perform a stat MRI if we needed to, which likely we would, but it won't actually help us get the seizure to stop. It also will not be effective if that patient's actively ceasing. We need to be able to see the imaging. So B is the answer here. Bolus of ketamine. This is an oncoming treatment, but it's not the first line for this refractory status epilepticus. Same with lacosamide. It can be used for seizures, but it won't help us in this emergency situation. Some status epilepticus information. Like I said, we consider it status epilepticus when we've got 5 minutes or more of ongoing, what we can see clinically as seizure activity, or what a EEG is showing us as seizure activity. Medical management wise, we're obviously watching out for ABCs. Want to treat with prompt anti-epileptic drug administration, which is typically that benzodiazepine. But if that doesn't work, that's when we're thinking, okay, we probably need a propofol infusion to really sedate and calm the brain down. Okay, wow, there's so much thunder outside right now. I wonder if you guys can hear that. Okay, another condition that I love to talk about here. So we've got a patient with T4 spinal cord injury, develops sudden hypertension, 200 over 110, bradycardia, and diaphoresis above the injury level. What is the most likely diagnosis, and what is the first intervention? Oh, you can't hear the thunder. It's a bummer. It's pretty loud. So yes, what do we think this patient has going on? And what are we going to do about it? Good job. Yeah, we've got some cardinal symptoms here, right? That should really let us know what's going on. Couple different answers though. Yeah, okay, let's go ahead and talk about it. Great job. Everyone seems to feel really good that it's autonomic dysreflexia. So we're saying B or D. That's awesome. The very first thing, if you have a known spinal cord patient and you look at their monitor, you're outside the room and you see their blood pressure is this high and they're bradycardic, those are two really cardinal symptoms, which I'll talk about why they present that way here in just a second. You see those two cardinal symptoms, the very first thing you're going to do is run in there, raise the head of the bed to try to get the blood pressure a little bit lower, reduce some of the blood flow up to the brain can be kind of dangerous. We might need to, so the answer here is going to be B. We might need to administer a labetalol or some sort of antihypertensive. Um, Absolutely, to bring that blood pressure down. We'll do that after we raise the head of the bed. We're likely going to need to call a doctor and say, hey, this is what's happening. Can I get an antihypertensive? And also in the meantime, right after I'm assessing this patient, raising the head of their bed, I am starting to see what is my trigger. What are some really common triggers for autonomic dysreflexia in our spinal cord patients? There's two or three that are definitely the most common. Yeah, good job, Shakira and Josfat. Sorry if I'm pronouncing that wrong. Those are right, though. They said full bladder. Exactly. We could have just any sort of bladder irritation. So UTI can cause this as well. Full bladder, likely with a spinal cord injury patient with autonomic dysreflexia, we're concerned for levels at the T6 level or above. So likely with those patients, they likely have a indwelling urinary catheter in, but it could be clamped. So we want to assess for that if there's any kinks. The tip of the catheter could also be irritating the inside of the bladder if it's maybe inserted too far or that sort of thing. The balloon, obviously should retract on its own, but in case there's some sort of positioning, malfunction there. So yes, full bladder. And then if it's not bladder, the second most common, Ashley said it, is a full bowel. So any sort of bowel distension can cause this as well. Tight clothes can cause this. The like snaps on the gown, if they get stuck up underneath the patient, little noxious stimuli that the rest of us feel and think, oh, I need to take care of that. It's not supposed to be crazy, crazy painful things, but you notice it. These patients are not going to notice it in the same way due to their spinal cord injury. And what happens with autonomic dysreflexia, which I feel like everyone feels probably pretty good about from these answers, is this trigger. We have these sensory neurons that take this information from the full bladder, try to get it back up to the spinal cord to tell the brain, hey, our bladder's full, but it gets stuck. That sensory information gets stuck at the level of injury, which for our patient was T4. But again, we're looking out for this for any injury above T6 or T6. So that information can't get all the way up to the brain. And then that causes the lower half of the body to kind of freak out, go into a sympathetic nervous system response in response to this, again, kind of painful stimuli. And that's going to cause that major league hypertension. Now, up above the level of injury, we have carotid arteries that are realizing, wow, our blood pressure is super high. And the brain is going to say, well, I know what to do about that. I'm going to reduce the cardiac output, and I'm going to try to stimulate the peripheral or the parasympathetic nervous system. And at that level of injury, we can still innervate the heart and say, hey, slow down, slow your heart rate down to reduce this blood pressure. And that's where we get that bradycardia. So up top, we can see the parasympathetic nervous system being in control as the brain tries to get this system to calm down, but it gets blocked. That parasympathetic nervous system stimulus can't make it through this site of injury. So we've got sympathetic nervous system going crazy and it can't be shut down. So the true key to treating this is finding the trigger and resolving the trigger. In the meantime, if we need to administer some sort of antihypertensive, then we can do that. But ideally, we'll notice, oh, wow, we've got a full bladder. Let's place a catheter right now, and we can get this to shut itself down. The other thing I want to mention, labetalol would probably not be the choice. We would likely give something like hydralazine, which is more of a pure vasodilator. Labetalol is going to reduce our heart rate, and bradycardia, we're already bradycardic. So we'll probably avoid that particular antihypertensive. So again, first thing we're going to do, elevate the head of the bed, then assess for trigger and see if we need to give an antihypertensive in the meantime. Okay, awesome job. Next question. I'm kind of running out of time. I'm going to see if this is the one yeah, we can do this one. I just like to pick and choose my favorite questions. A patient with a ventriculostomy for subarachnoid hemorrhage develops a fever of 38.9 and cloudy CSF drainage. The CSF analysis shows pleocytosis and low glucose. What is the most likely diagnosis and what is the first intervention? I see you thinking, Shakira. That's good. Okay. So pretty much almost everyone is saying B for meningitis. And I don't blame you. You're seeing, I know what symptoms you're looking at, and you're saying that's meningitis. But with our, the low glucose and a cloudy CSF, that's absolutely meningitis. Well, the CSF can be affected when we have a ventricular drain in place, and we can get an infection of the CSF that way too. So it might not be a meningeal infection like meningitis. We can have ventriculitis. So this is ventriculitis, which is told to us which is what we would suspect because we have a ventriculostomy, which obviously opens the highway of infection up to that area. So that narrows it down here to A and D. We are suspecting ventriculitis. Again, it could be meningitis as well, but most likely ventriculitis because we've got that ventriculostomy drain in place. Now, what do? Do we administer antibiotics or do we remove the ventriculostomy? In this case, we are going to administer antibiotics. So the answer for this one is A, which I think somebody got. Yeah, good job. So yeah, the answer here is A. Now, in a lot of different conditions, we would want to remove whatever caused it. Clearly, this was caused by the ventriculostomy, this infection. We would want to remove it. Likely, though, if we have somebody who needs a ventriculostomy, then they need it. So we are not really going to just be able to remove that catheter. We might be able to replace it, get a new one in place, but we can't remove it altogether. Maybe something that could be considered later, but would not be our first line. I've seen this with central line infections too. We'll swap those lines out, but if somebody needs a central line, we're likely going to keep them with a central line. We will maybe, again, swap it out, but with this ventriculostomy, we might not. And yeah, I get that, Shira, that you would have thought to remove it. With certain devices, absolutely. With this patient just would probably not be able to afford to have theirs removed. So I totally get that. Like I said, I picked kind of harder questions for today than normal. So these are not easy questions. Okay, this is going to be our last. And somebody said, why not be? Why not be? Even though we're seeing these symptoms that look like meningitis, there's still things that could be caused by any CSF infection. We blame CSF infections so quickly on meningitis, but if we've got somebody with an open catheter to that ventricle, it could be ventriculitis. And we would suspect that because that catheter is in place. Okay, which of the following findings in a patient with increased ICP indicates impending herniation? Yeah, a few different answers. The best answer here is going to be C. Dilated, non-reactive pupil with Cushing's triad, which is a big indicator for herniation. Now, the other answer that I got a lot of was D, which I totally understand, that fixed mid-position pupil with hypertension. Hypertension is part of Cushing's triad, so that makes sense. It just doesn't paint the full picture. And good job, Shakira. Yeah, I see you. And good job, Bailey. With that pupil, we would also expect it to be dilated with herniation. Either one pupil is dilated, kind of depends on where our herniation's occurring, or they both are. But that dilated non-reactive pupil really can tell us a lot about herniation, and especially alongside Cushing triad symptoms. So C is our best answer there. Really quickly, can someone tell me, my last question that I had refers to calculating your CPP. Can someone tell me how we calculate cerebral perfusion pressure? Just pop the equation in the chat. Yeah, great job, Ashley. Yeah, so it's going to be MAP minus ICP. Exactly. That just allows me to skip that last question and we can talk a little bit about ICP with our last, I'm going over, but just our last couple minutes here. Awesome. Good job. So yes, intracranial pressure. First, it's important to talk about this Monroe-Kelly hypothesis. This is a concept that's listed on the CCRN test plan as well, to keep in mind that our skull is a rigid, inflexible, stiff box, and it contains the brain, blood, and CSF. And ideally, if something gets out of proportion, then other things kind of adjust for that, or else our ICP is going to go up. So if we have a bleed occurring and now we've got lots more blood in the brain, lots more blood in the skull than we did before, and the tissue and CSF can't compensate for that, then that's when we'll see that increased ICP. Normal ICP is going to be 0 to 15. We definitely want to keep it under 20. When it's over that 20 range, that's when we're more concerned and intervening on that ICP. So cerebral perfusion pressure, this is why I want to talk about it before we got here, that equals your MAP minus your ICP. So your intracranial pressure is going to push against the blood flow that's coming up from the heart. So we've got that MAP, that mean arterial pressure, trying to feed the heart with blood. We are not going to get as trying to feed the brain with blood. We're not going to get as much blood to the brain if our ICP is elevated, which means we've got kind of an interesting balance to play. Because blood pressure itself can increase ICP. If we're really hypertensive, that can increase our intracranial pressure. So we don't want to just shoot for as high a MAP as possible when we've got elevated ICP to help make sure we've got a good cerebral perfusion pressure, because that can ultimately increase our ICP. So this is a balance that we play with at the bedside. Our goal cerebral perfusion pressure is 60 to 70. Which usually works out. Normally, if you and I walking around, we probably have a map closer to 80, even higher than that, 70 to 80. And then our ICP is 5 to 10. So we're really well within that range. But as soon as one of those things is not right, we're messing up with our blood flow to the brain. Increased ICP assessment. So earlier on, we can see the headaches, nausea and vomiting, confusion, altered mental status, and weakness. Those are earlier signs. Once we start to get to those pupil changes, Cushing's triad and posturing, those are late signs that usually are indicative of some amount of herniation. Doesn't mean you're necessarily at herniation just yet, but you either are there or it's impending. It's happening imminently and things need to happen fast. We can see a couple different types of herniation, like cingulate, central, or uncal. The down through the base of the brain is definitely the most dangerous, which is that central herniation. Okay, in posturing, remember, we can have decorticate or decerebrate. Decerebrate, where we have that extension outwards, is more severe. Bedside monitoring, we can do this with intraventricular drains. Like we talked about, those are not, we've got to keep that system clean or else we can cause that ventriculitis. We can have intraparenchymal intracranial pressure monitoring as well. Moving kind of quickly. Reduction lowering techniques keep our head of bed greater than 30 degrees. Neck midline for JVD drainage, not JVD, jugular venous drainage, not distension, but just allowing blood to flow from the brain. Keep our temperature normothermic. Cluster care, that's when we're talking about that suctioning. And then we can place an EVD to reduce ICP, do craniectomy. We didn't really talk about pharmacology for this today, but osmotic therapy like mannitol, hypertonic saline helps pull fluid out of the brain tissue and into the bloodstream to be excreted by the kidneys. Treat hypotension and potentially cause hypertension, but be careful with that. We might do it in some instances, but we don't want to increase ICP either. Sedatives and pain treatments, and potentially paralytics if we have to really reduce that stimulation. Yeah, towards the core. Towards the cord. Yeah, always remembering decorticate as towards the core, towards the cord. Yep, that's how I remember it too. That's a good option. And here's just a list of procedures, all that we can do for ICP management. Okay, I'm sufficiently over. But we talked about a lot of different concepts today. I know those were tricky questions. Somebody's asking, why don't we do isotonic fluid for ICP management? It's not to say that you can't give a patient with ICP isotonic fluid like normal saline. It just won't help the problem. So if we're using fluid to help pull different fluid, pull fluid out of the cerebral tissue, we need hypertonic because it causes that necessary fluid shift. The blood will be more concentrated and naturally fluid will flow into the blood to try to balance that out. So hypertonic saline would be necessary to pull fluid out of the brain tissue and get us that reduction in ICP. Good question. Okay. Oh, something's happening here. Oh, wait, no, I think y'all can see it. Let me just check. My image looks weird. This is our next webinar QR code, which luckily I think you can see. So yes, sign up for our next webinar. This is going to be on mechanical ventilation, which I'm super excited about. This is something that as a bedside ICU nurse, we have ventilated patients all the time, but our nursing school education on ventilators is like nothing. So sometimes you get thrown into the ICU and you just feel like, oh my gosh, I have no idea what that is. And there is a respiratory therapist there to help you and really manage that side of things. But as the bedside nurse, we want to feel pretty comfortable with our modes and our settings and what type of modes are appropriate for what patients, how to troubleshoot alarms, because we're really the ones doing that, at least initially. We're walking into the room at first and then calling the respiratory therapist if we need them. So really excited about this one. It's going to be next Monday at 11 a.m. Central Time. Um, if this one, we are going to be offering CE hours for. The caveat with getting a contact hour certificate with these webinars is you have to sign up for them with this link or go to archerreview.com/CCRN and find this webinar on the site and sign up for it so that you get a Zoom link. And then you can join via Zoom so that we can track how long you were here. In order to qualify to receive this certificate for this webinar, you would need to attend for 80% of it. It's just an hour long. And that way, then we can verify that you were here for that amount of time. If you join on social media, we can't verify the time you were here. So definitely sign up for this one on the site, get that Zoom link in your email, and then we will see you next Monday. Okay, was this helpful, everyone? Did we learn anything? I know it was a little bit tricky. But just let me know if this was helpful. And then I will let you go. Okay, good, Shakira. Awesome. So exciting. I know it's neuro is just a tricky little one, which for me, I know I avoided it for a really long time in my career. So if you're in that boat, I completely understand. All right, everyone, I will let you go.